Hello, today we're going to be discussing sickle cell anemia. So we're going to go back to our physiology and discuss hemoglobin and the shape of the red blood cell. So the shape of the red blood cell is a biconcavity type shape or a donut type shape, and the reason why it is it optimizes the cell surface, or it increases the cell surface area for gas exchange. It also helps with deformability in the capillary bed, so they can kind of squish through there and get to the tissue to release oxygen to the tissues, and then get back into the venous system and get back to the heart. So hemoglobin is a unique pigment which contains heme groups of iron compounds, as we all know, that O2 binds to. It also plays an important role as a buffering agent for hydrogen ions when carbonic acid is converted to bicarb and a hydronium ion. The structure consists of globin and heme groups, 4 of each. Globin, which is the part of hemoglobin that is affected by sickle cell anemia, consists of 4 polypeptide chains, 2 alpha molecules, and 2 molecules of another type. Each RBC contains hundreds of these hemoglobin molecules. So we have hemoglobin A, hemoglobin A2, and embryonic and fetal hemoglobin, which are the 4 main types of hemoglobin in the human lifespan, or the normal human lifespan. The most prevalent is hemoglobin A, and accounts for roughly 96% of the hemoglobin in adults, and as we know, 2 alpha and 2 beta chains. Hemoglobin A2 only comprises of about 2% in a healthy adult, and actually has a 2 delta instead of 2 beta chains. Embryonic is replaced with hemoglobin F, or fetal hemoglobin, by the end of the first trimester. And then you have fetal hemoglobin, which is replaced then by hemoglobin A in infancy in a normal adult. And by adulthood, we only have about 0.6% of this going around our body. So the production of hemoglobin it begins with a globin chain. It is controlled by an individual gene within 5 loci. Any mutations that occur within these 5 loci, you end up with a hemoglobinopathy. And the prototypical form is sickle cell anemia. So trait versus disease. First, we're going to talk about the trait here. It is the heterozygous form of the autosomal recessive disease of sickle cell. It occurs in nearly 10% of African Americans. That is a huge portion of African Americans that are probably walking around with a sickle cell trait, and they are unaware of it. They are typically asymptomatic unless they also have hemoglobin C. Hemoglobin S comprises of usually less than 40% of the hemoglobin in sickle cell trait. Strangely enough, it actually protects against malaria. Sickle cell disease is a homozygous form. It is the most common familial hemolytic anemia in the world and occurs 0.2% of African Americans. It presents in infancy with hemolytic anemia as hemoglobin F is replaced with hemoglobin S instead of hemoglobin A. It comprises of more than 80% of the total hemoglobin. It eventually progresses to end organ damage, mainly in bone marrow, spleen, kidneys, and the CNS, but it can affect any organ system whatsoever in the body. So how this disease works is you have hypoxemia, which causes the hemoglobin to become less soluble. It crystallizes, and it leads to the distorted sickling shape, impaired deformability, as we discussed. Without that deformability, the red blood cell has problems getting through the capillary bed. You have a decreased RBC lifespan to only 10 to 20 days, which is only a fraction of what a normal red blood cell lifespan is. You also have episodes of pain crises. So over here you have the normal hemoglobin, and here this is hemoglobin S. You have these little outlets that stick out here. Whenever that becomes deoxygenated, which is this one, you end up with these little binding sites here on the alpha chain, and which leads to crystallization, and they kind of piggyback on each other, and you end up with these chains all along here, long chains, which is what deforms the red blood cell to look the way it is. So again, it's just a single point mutation of an adenine and a thymine. Those are just inverted here. And it transcribes a uracil instead of an adenine, and you end up with valine instead of glutamic acid. So anatomic and physiological alterations that this disease causes is severe chronic hemolytic anemia, increased breakdown of heme, which leads to bilirubin buildup, and then you have microvascular obstructions, which provoke tissue ischemia and infarction. Many of these sicklers, as they're known, end up with splenomegaly, which occurs mainly in children, and it's due to red pulp congestion related to the sickle cell entrapment. And it causes erythrostasis and hypoxic damage and infarcts in the spleen. Over time, the spleen is reduced to a useless nubbin of fibrous tissue. Poor splenic function increases the susceptibility to infection from encapsulated bacteria such as S. pneumoniae. And encapsulated bacteria is actually different than just gram-negative bacteria. I'm not going to go into the details, but it is different, and you may want to take a look at that. You also end up with vascular congestion, hypercoagulability due to deformed RBCs causing vascular occlusions. Thrombosis and infarctions can affect any organ in the body, especially bones, retinas, kidneys, lungs, and brain. Bone marrow is particularly prone because the sluggish blood flow, and the high metabolism that it has. You also can have hemosiderosis and gallstones. The hemosiderosis is basically iron sediment that ends up depositing in tissues and can cause many issues. One of them is lung diseases and etc., etc. But it can end up in any tissue in the body. Here we've got our little red blood cell, becomes deoxygenated, and it deforms into this sickle-like shape from the crystallized hemoglobin. Now, we have one of two paths. We can either become irreversibly sickled, or we can become oxygenated again and go back to our normal shape, and we can kind of go back and forth through this whole cycle of becoming sickled and not sickled. And while it's sickled, though, it can cause microvascular occlusions, which can lead to more hypoxemia and more sickling. So the secondary disease processes, the three main ones, are neurological, pulmonary, and infection. So we have stroke. It usually is the result of arterial disease rather than sickling in the adolescent. Adolescents usually present with cerebral infarction, and adults are more likely to develop some sort of hemorrhage. The pulmonary issues that they tend to have is known as acute chest syndrome, and they present with a pneumonia-like disease. It's usually triggered by a pulmonary infection or a fat emboli. They end up with an ischemic lung, which leads to a very vicious cycle of hypoxemia, sickling, and then vasoocclusion. And guess what that vasoocclusion does? It causes more hypoxemia, which leads to more sickling, which leads to vasoocclusion. You end up with this vicious cycle. So infection, they can end up with an aplastic crisis, which is triggered by parvovirus B19. It's usually self-limiting and infects the RBCs and interferes with the production of RBCs. Usually the highest mortality is, and most common, are these two. These two is the stroke and the acute chest syndrome. So the mainstay treatment, the main treatment that they are given is hydroxyurea. It's described as a gentle DNA synthesis inhibitor and reduces pain crises and lessens anemia. How does it do this? It actually increases the hemoglobin F, which is only about 0.6% in a normal adult. So it increases the amount of fetal hemoglobin. It inhibits white blood cell production, which counteracts the inflammatory process that's associated with this. It increases the RBC size, thus lowering the mean cell hemoglobin. Metabolite is nitric oxide, potent vasodilator, and inhibitor of platelet aggregation. So it inhibits aggregation of platelets, which decreases occlusion or vasoocclusion. So here's a list of risk factors that lead to peri-op complications. We have advanced age, recent severe episodes of sickling, evidence of end organ damage, increased creatinine, cardiac dysfunction, any history of stroke whatsoever, concurrent infection, and type of surgery. Inguinal hernia repair being the lesser of the three, and craniotomy being the most likely to cause complications. Hip surgery is especially problemsome due to the excessive blood loss, which can lead to hypoxemia and more vasoocclusion. The pre-op considerations. Transfusion is only required if they are undergoing a moderate to high-risk procedure and if the hematocrit is less than 30. Other than that, it is not recommended whatsoever. So the primary goals is actually to avoid 4 main issues with sickle cell. You want to avoid hypoxemia, dehydration, acidosis, and hypothermia. So in order to prevent hypoxemia, we want to denitrogenate and denitrogenate well, especially if we think we're going to have any issues whatsoever. Also, we want to keep them well hydrated, give them a nice bolus before we even get back to the OR, and keep them maintained during the procedure itself. Acidosis, we want to keep them right where we would any other patient, between 30 and 35. So if they are unable to maintain that with spontaneous ventilation, we want to bring them back down to roughly that area. Hypothermia, we want to use an esophageal temp probe and a bear hugger for any procedures that we anticipate greater than 30 minutes. If we're really not sure, throw a bear hugger on there anyway. Post-op considerations, pain control, and be aware of acute chest syndrome. Pain control is a major player in post-op complications. If we don't control their pain, then that can lead to a pain crisis and lead to more complications such as vasoocclusions, etc. So make sure to load on your opioids and non-opioids. Use multimodal prevention or pain treatment for these guys. And don't be afraid to give them opioids because they're probably tolerant because of the pain crises that's associated with this disease. Also, acute chest syndrome, be aware of that. It may develop 2 to 3 days into the post-op period. Treatment, you want to focus in on hypoxemia, pain, and anemia, etc. Basically, just treatment for the disease. Nitric oxide may be used to improve pulmonary hypertension and oxygenation. Also, regional anesthesia can be a good option, but it can also lead to some complications, so just be careful with that. Also, postoperatively, you want to monitor for pain crises, stroke, and infection. And here are my references. Thank you.